This patient has very advanced corneal endothelial dystrophy. You can see the guttata in the center of the cornea there. They actually go out to the edge of the pupil even. And a Bell's phenomenon. So I'm going to rotate her down because we're going to mark for toric IOL here. And the desired axis is 70 degrees. So there we go with that. She's also has a very shallow chamber. Now, some patients with a shallow chamber will deepen adequately when you inject OVD, and some will not. And the ones that will deepen adequately tend to be the ones with a low intraocular pressure pre-op. So that when you increase the IOP with the OVD injection, you deepen the chamber. Okay, let me have the cotton tip applicator back. So there's not a lot of room over here for my finger. So I'm going to actually use a cotton tip applicator to stabilize the globe and kind of wiggle in. And it's a shallow chamber, so I want to get in slowly. And I can just now clear Decimaze there. And I'm just going to, again, I don't care how long it takes to get in. I just don't want to suddenly pop in. You know what I'm going to do? I'm going to come out now and put in some OVD and see if I can deepen it. Actually, lidocaine first, and then I'll complete that entry. Little sting. Wet the cornea. And now the OVD. Yeah, and the chamber is deepened nicely. And I thought it might because her pre-op IOP was like 9. If the pre-op IOP is, I'm going to say a number like 18 or 20, they won't deepen significantly unless they have very poor ocular rigidity and the sclera can expand. And that's typical only of high myopes. Okay. So we filled the eye with Visco. Now I'm putting in some Provisc, and I'm going to incise the anterior capsule as you just saw me do there. And now I'm going to position the globe with the side port instrument. And perform the Capsulorhexis. What I'm doing is I'm just following the pupillary margin. So I get a fairly uniform Capsulorhexis there. Okay, so the next step is to perform the hydrodissection. You could see the fluid wave go slowly across and not all the way either. And then I did the other side. And then we're going to do viscodissection. Now, we don't have a deep chamber here by any means, but we have what I believe is an adequate chamber for phacoemulsification. And I'm doing 360 degrees of viscodissection here. So, our phaco tip, sleeve adjusted to get good flow out of both eyes. Let out a little OVD so I can do a no-touch insertion. And the next thing I'm going to do is I'm going to aspirate only, deepen the chamber by removing the anterior lens layers before beginning ultrasound to create the bowl in the middle. And then I'm going to stabilize this lens with the cornea. Again, wet the cornea. Good. Okay, so I know I can chop it now, but I'm not going to make quadrants. I'm going to make eighths, because I want to remove small fragments of this nucleus, basically in situ, quadrant removal. Because the better job I can do removing them without bringing them very far forward, and getting them near the endothelium, the happier the endothelium is. Trimming that down a little bit, and then we'll rotate it over. And let's see if we can now chop this one remaining segment. And if I can't, because it's kind of loose, I'm going to turn it sideways and just remove it in situ. I take some epinucleus here. Even that gives me more space to rotate smaller chunks of nucleus. And again, with the cornea, keeping them away from the endothelium. And even now, right in the middle of this procedure, I'm going to put some more viscoat right in the center. We'll just pause for a second here and get some more. Everything's fine, no flow, nothing going in and out of the eye. And this technique of putting more viscoat in the eye, I'm going to use my left hand and my thumb on the plunger. And if I can get a finger down on the eye, on the periorbital area, to stabilize my hand, then when I get in, I'll go to position 0 and just inject more viscoat right in the center without ever coming out. Because if I came out of the eye, the chamber might shallow enough and that last remaining segment might come forward. So this is just all protect that endothelium. I mean, the endothelial cell count in here is no visible endothelium, really. You just can't see any. Okay, so now we're ready for INA. And we're using a 90-degree INA tip spatula. The guttata in this eye are enough to create a certain corneal haze that we're looking through. But that doesn't mean the patient must automatically go and have a dissection procedure. With the cataract removed, the acuity might just be fine for a long time. Now in these eyes, at the end of this case, we're going to still have that viscoat right up against the endothelium. I won't be aspirating it. So they have to be watched carefully for a potential pressure spike. I'll just aspirate some epithelium here from under the anterior capsule. And now we're going to put in our toric IOL. And our marked axis is 70 degrees. Now that's a long way to rotate this lens. Easy to rotate it a long way before it completely opens. So I'll get it almost to the 70-degree location. And now we're going to remove the OVD, but mostly just from behind the IOL. And because we're leaving OVD, and we know that that means there's a greater chance for a pressure spike, we'll check this patient's pressure in about an hour. And we'll also put in some myostat to lower IOP for the next 24 hours or so. So now I've lined up the toric IOL parallel to the corneal marks, as you could see there. It's a slightly nasal position, so it's parallel to the marks. And now I'm going to perform stromal hydration. Irrigate a little bit out by the chamber angle to make sure there are no nuclear particles. But you can tell that there's OVD in the chamber. You can see these little microscopic particles in the center of the eye. That one there I might aspirate, like so. But you can see that there's still viscoat there. Okay, so next will be our myostat injection. And of course, most of the time when you do this, you're going to see the pupil come down. Maybe not to get very myotic, but to lose some of the dilation at least. And a little tip about doing that, if you do that in young people, some of them will immediately, within an hour or half an hour, have a big headache, ciliary spasm. You can reverse it with cyclogel or one of the dilating drops, Midraisil. But of course you would block the pressure lowering effect. Okay, so we've got moderate constriction, and we'll check the pressure in about an hour in this eye with advanced corneal endothelial dystrophy.